Okay, so good morning. I'm Pieter Uvin, urologist from Bruges, and I will about to start a HoLEP procedure in a patient with a benign prostate obstruction and a prostate of around 100 grams. So we're now inside the bladder, which, as you see, looks a little bit trabeculated. We tried to find urethral orifices, which was a bit tricky because they're quite close to the bladder neck, as you see here. See the orifice is actually very close, so we will have to be careful. The one at the left side, I don't even find at this stage, so that will be something we will have to take into account at the end of the procedure. So what we will now do now is to start the procedure at the apex. So we will create the white line, as we call, by making a mucosal incision right at the edge between the mucosa on the sphincter, which is this mucosa, and the mucosa on the adenoma, which is this mucosa. So we will start the procedure now by making this white line incision. And I have quite easy access to the anterior side of the prostate, so that's why I tried to develop the line already a little bit more. And now we will circle around the verumontanum, which is here, in order to find the enucleation plane at the posterior side of the prostate. Okay. Let's have a look if we find the enucleation plane here. That should be it. Yeah, so that looks like the plane. So let's gently try to develop it. And I want to let the laser energy do the work, of course. So I will slowly dissect the enucleation plane here. And try to develop the posterior plane as much as possible until I feel resistance. So I will just proceed here at the posterior side in the direction of the bladder. But of course, when I feel that I cannot advance the instrument further, I will stop. I will never force the instrument further. That's a mistake, because you will tear tissues, you will maybe cause incontinence, you will create bleeding. So I just try to develop the posterior plane here very smoothly until I have the feeling that I have to stop. Here are some nodules which take away the vision on the plane. So I will cut here, and I will develop the posterior plane in the direction of the right prostate lobe. So now I'm actually under the right prostatic lobe. Okay. So we just proceed here. And we work our way in the direction of the bladder. So at this moment, I'm using the virtual basket setting with 2 joules and 50 hertz. It really gives a lot of power to dissect the enucleation planes in an efficient and easy way. It really opens up the plane. So that's the pedal and the setting that I mostly use. The other pedal that I have is the Magneto setting, and I use this for coagulation. It has good coagulation properties. At this moment, in this phase of the procedure, it's not necessary for me to use it a lot. Sometimes I have a bleeding that I want to stop, but the major part of the procedure, especially in the beginning, I use the virtual basket setting and not the Magneto setting. Although at the end, before morcellation, I will do a hemostatic phase, and then I will use the Magneto setting. And of course, also if I have a bleeder doing the procedure, that sounds only logical. Okay, so now I'm dissecting under the right lateral lobe. And as you see, I always try to keep this connected with the posterior plane. So the posterior line where I am now is in connection with the lateral side of the prostate. Just a little bit more, and then I will stop this side. Okay, that's enough. And now I will do the same at the left side. Let's have a look here. This is the white line that I created in the beginning. So I will deepen this out now, and I will try to find the enucleation plane here and connect it with the posterior plane, as always. It's always a game of connecting dissection planes. So here is some tissue that needs to go. Okay. Okay, and I work my way now. I'm working under the left lateral lobe, which I connect with the posterior line here. Okay, so that's going fine. Okay, so I've done enough for this phase of the procedure. So now I will turn my instrument and I put the fiber at 12 o'clock. Okay, I put the fiber at 12 o'clock. I pull my scope back and I have a look again at the white line that I created in the beginning, which is here. This is the white line that I created in the beginning. Here is the sphincter that I need to preserve. Here is the sphincter. And I want to cut on the adenoma right under the sphincter. So right under the mucosal incision that I did in the beginning, I cut on the adenoma and I release the adenoma. So this is the early apical release. So I mobilize the adenoma. I'm not thinking about enucleation planes at this moment. I just want to mobilize. I just want to mobilize. And that's what I'm doing now. I just want to create access in order to be able to circle around the prostate in the next phase of the procedure. So that's what I'm doing now. I'm just cutting on the adenoma and creating space for myself. Okay, so that phase is done. And now I'm looking at the plane again, and I'm going up, and I'm dissecting the lateral side of the prostate. This is the lateral plane, the right lateral plane, which opens up nicely, as you see. So this goes very smooth. I do not have to push the instrument, so I can just proceed here and work my way around the prostate. I really want to have this nicely mobilized. So there you see that it's quite thin. This is getting quite thin. So I know I have to be careful there. So I go a little bit medial. I go a little bit more on the prostate itself. I go a little bit more on the adenoma. I do not want to make a perforation here. You see, this is quite thin. So I stop there and I go a little bit more medial. So that's enough. I want to first have a complete apical release. So I pull my scope back and I look what I have to do. And I have to go up here. Okay. So I pull my scope back and I circle around the apex. I try to go up, 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 up. Okay. I go up. And I connect this incision. There you see the lateral plane that I developed in the beginning. And I go up here. Okay. Looks nice. Okay. Okay. So that's enough for this phase. And now I will do the same at the left side. So as you see here, the right apex is developed, is released, and now I will do this for the left apex. So I will create first space here, and I will slide into the plane at the posterior left side of the apex. I will put some tension, as you see, on the adenoma and circle my way around it while maintaining the connection with the posterior side. So here you see the adenoma is being freed quite nicely. This is a plane that we can easily develop. Okay, so that's enough. So I come back and I go up. Okay. Again, I come back and I go up. And I circle around the apex. I create space, I mobilize the adenoma, and I circle around the apex. Okay, that's enough. That's something for Magneto. You see this bleeder? So I use the Magneto setting here. And then I continue the dissection. This is the anterior plane. Okay. All right. Now we have to see what we still need to do in order to make the connection with the left side. So that's here. Okay, so that looks good. Let's have a look at the other side. So that's there. So this is what's still interfering with having a complete anterior apical release. So here you have the right anterior apical plane. Here you have the left anterior apical plane. And now we need to cut this bridge, and then everything is connected. So let's just cut through it as high as possible in order to take this benign tissue with us. Okay. Okay. All right. Okay, and I connect it to the right lateral plane, which I already developed before. Okay. So this goes nice and smooth. Okay. And now we have a complete apical release, and I develop this plane further in the direction of the bladder neck. So this allows me to put my instrument on top of the adenoma, and in this way I can gently pull the adenoma down. That gives some traction on the fiber that I have to cut. And that allows me to proceed in the right plane in an efficient way. Okay, so this is all done. So now we can extend this anterior plane right until the bladder neck. Let's do that. Okay, so as you see, this goes smooth. You can develop the plane here. My instrument is pushing down the adenoma. And I try to make wide movements, as you see. I try to make wide movements between 10 o'clock and 2 o'clock. I don't see it yet, but I think that the bladder will not be far away. There I have the, yeah, that looks like the bladder neck fibers. So that means that the bladder is right under here. So I keep my laser fiber at 12 o'clock, and I keep developing the anterior plane. That's good. Okay. Voila. So here you see the bladder neck fibers. So this is for sure the bladder neck. So let's wait until we open the bladder completely. Why? Because if you open the bladder now completely, you lose some of the advantages of doing an en-bloc approach. One of the nice things about having an en-bloc approach is that you have a very tight space, and this tight space make sure that you have good hemostasis, that you do not use a lot of fluids. So that's an advantage that we can actually exploit by not opening the bladder neck immediately now. So I will just wait just a little bit longer with going inside the bladder, and I will just circle around the prostate. Okay. Okay. Okay, so now the time has come to open the bladder and to have a look inside the bladder. So let's open the bladder at 12 o'clock, and let's make an incision from 2 o'clock around here until 10 o'clock. Okay, so that was 2 o'clock. Here is 10 o'clock, and then I will stop. I will put my fiber at 6 o'clock and work my way around the prostate. So as you have seen in the beginning of the procedure, the urethral orifices are very, very, very close. So we will have to be careful. So I do not want to go down here, just preparing everything. So this looks good. Okay. Now let's put the fiber at 6 o'clock. And let's have a look. First we have to find our orifices, because that's what we want. Yeah, okay. Here is the orifice here. So now I want to medialize the incision . Yeah, it's here. So you have to be careful, for sure. They're very close. Okay. So I'm medial from the orifices, from the left orifice here. Okay, so that's good. So this is a way of making sure that you do not inadvertently injure the orifice, which is of course a problem. I had one patient in which I had to place a double G stent after the procedure because I injured the orifice. Yeah, that was not a nice experience, so I really do my best to avoid it. I was lucky also that it was possible to place the double J stent, because it could also have been the case. So this is the orifice on, no, here is the orifice. Maybe this patient, it looks just diverticulum and the orifice. So looks like a diverticulum. I was thinking that it was like a second orifice, which is not impossible, but it would be a surprise for me. No, it looks blind. This is more like a diverticulum, okay? And the orifice is here. So in the beginning, what I thought was the orifice was actually not an orifice, and it was a diverticulum. So the true urethral orifice is here. So this actually proves why, with an en-bloc approach, when you come from 12 o'clock and you go down with your laser fiber, it's actually a very safe way to to be careful with the orifices, because in the beginning, I was thinking that it was here. And when I would be doing a classical 3-lobe incision and I would be doing a bladder neck incision here, maybe I would have made a mistake by making a bladder neck incision here because I thought this was the orifice. So this actually proves why you are safe with the orifices when doing an en-bloc approach. Okay, it's good that we identified it. Now let's work our way careful around it. Okay, that's see, they're very close. Okay. So I medialize the bladder neck incision. That's a bit too deep. Okay. Okay. I'm mobilizing it here, making sure that I don't create a big perforation here. All right. Let's work our way around it. Okay. All right. Okay. Almost done. All right. Okay. Let's see what's still hanging. Okay. Just here. Okay, we're done. So this was what I thought was the orifice in the beginning of the procedure, but I was wrong. The real orifice at the right side is here, which is nicely preserved. Although you see that the prostate was just growing like subtrigally right under the orifice. And the other orifice is here. I will just cut out this piece of tissue in order to be complete. Okay, and then we're done with the enucleation. So, interesting case, for sure. So I'm very happy I did an en-bloc procedure here, and I came from 12 o'clock down to have a look at the orifices. So here you see that the sphincter is nicely preserved, so that's good. Here you enter the prostate, and everything here looks good. Okay. I will just have a last look for the hemostasis with the Magneto setting. So this is Magneto doing its work. That's good. This looks good without too much bleeding. That's good. And then we will go for morcellation. Okay. Now we enter with the morcellator inside the bladder. This is the tissue that we have to morcellate. Okay. And we're starting the morcellation. So as you see, with HoLEP, the visualization is a little bit reduced, but it's enough to go for a safe procedure. Okay. So the next patient is already okay. Thank you. So in order to have a safe morcellation, I want to have the bladder completely filled. I use 2 inflows. It's not really necessary, but I think for safety, it's what I use. Huh? I also want to have a good hemostasis before starting the procedure. Of course, you need to have the nurses paying attention to the water bags, because you don't want them to be completely empty. And it's also important to have the technical departments doing the necessary maintenance of your equipment. The hand pieces, for example, need technical maintenance, so that's quite important. So. Because this should be a quite stressless, easy phase of the procedure. You should be able to put the music a little bit louder now. Huh? But of course, it can be really dangerous as well. Huh? So there's a case report described where they had a bowel lesion after morcellation. So these things are described and they can happen. Huh? So I hope that was the last bit. Let's have a look. Yeah. Let's have a last look inside the prostate to see if everything is. No, that's the video. Okay. This looks nice and good. Okay. That looks good. So now we will have a short last coagulation phase. I will have a quick look inside the prostate to see if there's no major bleeding, to see if there is no piece of tissue that I left behind accidentally. I think it's just a way of playing it safe. It's not really necessary. Maybe I could just place a catheter right now, but I feel a bit more safe if I have a last check of the hemostasis of the prostate. Okay, let's have a look. Okay, so my laser is on again. These are very tiny pieces, no problem. Yeah, so this is the Magneto setting doing its work. That looks nice. We're almost finished to put it. Okay. So again, this was, this is the right orifice, not this one. Let's have a look at the left orifice. Yeah, that's here. Okay, so that's the left orifice, so that looks nice. Very close, of course, but nice. So, yeah. Okay, so we can stop the procedure. Okay, let's place a catheter.